Welcome. I'm Leslie Canham.
I'm Mary Gavoni.
I'm Linda Harvey.
I'm Olivia Wan, and together we are the Compliance Divas.
Welcome to the Compliance Divas podcast. I'm Mary Gavoni, and I'll be the moderator for this episode. We bring clarity and simplicity to compliance by navigating the regulatory world to keep you on course. You can subscribe to the Compliance Divas podcast through your favorite podcast channel or on our website, thecompliancedivas.com. All the resources we mentioned during this episode can be found on our website, thecompliancedivas.com, and you can always submit questions and feedback to support@thecompliancedivas.com. The topic for this episode is antibiotic stewardship, and you may have heard this term or read some news feeds about it. It's becoming a very hot topic in dentistry and all of healthcare. And antibiotic stewardship, if you're not familiar with it, is a concept that's gaining a great deal of attention because of the increase in antibiotic resistance, but also an increase in the number of cases of C. diff or Clostridium difficile, which can actually be fatal to some patients. So the principles of antibiotic stewardship seek to improve how antibiotics are prescribed by clinicians and how they're used by patients. According to the American Dental Association, dentists prescribe about 10% of the antibiotics that are prescribed in outpatient settings. So that's a fairly large number. Dentistry is being tapped to help be a part of this movement. So, Olivia, I'd like to start with you. And can you give us some background on antibiotic stewardship and why there's a need for improving prescribing in outpatient settings, which dentistry is, and in particular in dentistry?
Well, I think you brought up some really good points, Mary, that most of the antibiotic prescribing is coming from outpatient facilities. And as you indicated, dentists account for at least 10% of that. And so with the increase of antibiotic resistance and this digestive infection that could occur using antibiotics, we have to reevaluate our prescribing and whether dental practices are practicing this stewardship of antibiotics. We realize that the antibiotics, when prescribed, can result in complications. And the side effects could be something as simple as a rash or diarrhea, but could be very severe, such as a severe allergic reaction or some of these other infections that we talked about. So with dentists accounting for outpatient facilities as well that are prescribing, they really need to adhere to this antibiotic stewardship program and get up to date and not just prescribe. I know we've talked about this in other episodes that it's almost like the patients expect to be given an antibiotic and a pain prescription. And there's been so much information over the years about opioids, but now it's time to step up to the plate with antibiotics and get away from that attitude when patients come in thinking that just because they had a tooth extracted or just because they had some type of procedure, that does not automatically warrant the dentist prescribing an antibiotic and opioid. So that's some of my thoughts, Mary, that I'm really glad that this topic is getting more attention and more ground. And I think I have fallen into that same category over the years, thinking that, well, if I get a little cold, I think if I go to my doctor, they should give me an antibiotic or some kind of prescription to make my copay worth it. But that's not the case at all. Because of this antibiotic resistance, we might find ourselves in a precarious situation if those antibiotics are no longer effective.
You are absolutely right, Olivia, and thank you for that information. It's, it is something that has developed over the years that there is that expectation, and or the doctors in many cases are concerned that their patients may have some post-op infection. So in the normal course of doing a procedure, a surgical procedure in particular, antibiotics are prescribed. And of course, we'll talk in a bit about the whole issue of prophylactic antibiotics and how much that has changed. The CDC has tremendous amount of resources about antibiotic stewardship in all kinds of settings, including outpatient settings. Linda, can you go over with us the 4 core elements of outpatient antibiotic stewardship?
Sure, Mary. These are so applicable to any outpatient setting. And I know you and Olivia have done a great job of mentioning what percentage of prescriptions dentists write and how we do need to be accountable for our prescription writing. And I think it's also a matter of resetting my patient's expectations. So I love what you said, Olivia, about the patients expecting to get their money's worth for their copay, and it doesn't necessarily equal to an antibiotic. So these 4 core elements, the first one is commitment. And that is to demonstrate your dedication to and accountability for optimizing antibiotic prescribing and patient safety. And, dentists and all of our dental teams are so in tune to patient safety and strive to have a safe patient visit every time. It's just a matter of looking at it a little differently and now beginning to reset the patient's expectations and verbalizing this to the patient as part of your commitment. Next is action for policy and practice. This involves implementing at least one policy or practice to improve antibiotic prescribing and assessing whether it's working, and then, of course, modify as needed. And to me, that this may not be, each of us may not have a written policy, Mary, although that's not a bad idea, but they could at least have a protocol outline of what patients they feel they're going to be needing to use an antibiotic and have an algorithm of decision questions so that way they have an idea of how they're going to move forward when they do need to prescribe antibiotics. And it reminds me of OSHA's post-exposure prophylactic, procedure and the follow-up for that. If this happens, do this. If it's not contaminated, then you do that. Was not a contaminated sharp. Let me be a little clearer on that. So third is tracking and reporting. Monitor your antibiotic prescribing practices and give feedback to one another within the group. If you're in a group practice or DSO or whatever the setting is, and there's more than one doctor, then help each other to assess your practices and seek, input from one another. And I'm wondering, could a report be run on the prescriptions that have been given to patients over a certain period of time? Another way is perhaps keeping a tracking log. And with a tracking log, I liken that, Mary, to the implant logs that a practice implements. And by doing so, you maybe add prescriptions written with your tracking log. And so you're also tracking implants at the same time in those serial numbers, which is important because if there's a device recall or there's an infection, then you need to notify the manufacturer under the Safe Medical Devices Act. And it's important, just kind of ties it all together so it doesn't create one more thing for the office to do. It just is a value add. And I also parallel this to controlled substances. With all the tracking that's being done in that world, how can you do something even minimal within your own practice to track and monitor and help to support one another for maintaining antibiotic stewardship? And last but not least is education and experience, Mary. That's providing educational resources to clinicians and even to patients on antibiotic prescribing. So I'm going to be thinking about here the fact that I've seen many of our medical providers in our area have little signs at the check-in on what their controlled substance policy is. How do we notify patients? Maybe we don't need one more sign in the reception area, but how do we notify patients of our antibiotic prescribing practices? Maybe that's in the literature that you give the patient when they're getting ready for dental surgeries and they understand what the protocol is. I think that it would be incumbent for doctors and even team members to take a CE course on this topic, read scientific articles, stay abreast of what our peers are doing and what the research shows so they can be on the cutting edge with that information. So where it comes back to these 4 things: commitment, action for policy and practice, tracking and reporting, education and experience. Because when I think about stewardship, I think about the definition that I read in the online Merriam-Webster dictionary. It's careful and responsible management of something entrusted to one's care. And our patients have been entrusted to us because they've chosen to come to us and chosen to have trust in us for their care. And they know we have their best interest at heart.
Well said, Linda. And I love the fact that you brought up the concept of the team participating in an education program about antibiotic stewardship. And the CDC just happens to have several available online. we will make those resources available, the links to those resources available on our website and in the show notes, so that any practice that would like to participate in that particular training program, what is antibiotic stewardship, and I believe you can also get continuing education credit for that, so that's always a plus. So Linda, you did a great job of summarizing the core elements of outpatient antibiotic stewardship, and part of that is really setting priorities for when we need to prescribe. So Leslie, can you walk us through the information that's provided to us from the CDC about prescribing antibiotics?
Well, Mary, sometimes there are high priority conditions for intervention with antibiotics, and high priority conditions are conditions for which clinicians commonly deviate from the best practices for antibiotic prescribing. And that includes conditions for which antibiotics are either overprescribed, underprescribed, misprescribed with the wrong antibiotic agent, dose, or duration. So sometimes when we talk about these conditions, we might want to think about how we recognize these in our own practice, because sometimes it's barriers where we deviate from the best practices because of outside influences. And that in addition to, let's say, a knowledge gap about a best practice and clinical guidelines, the clinician's perception of patient expectation for antibiotics, like Olivia was talking about, I don't feel well, so an antibiotic is going to cure me, or perceived pressure to see patients quickly. And as we all know, when a patient feels like they have an emergency, they want to be seen now. Or clinician concerns about decreased patient satisfaction with clinical visits when antibiotics are not prescribed. So you can see how there are other pressures, scheduling, patient pressure, patient expectations, and feeling like we might be letting the patient down. There's also sometimes examples of high priority conditions for improving antibiotic prescribing. And so we do need to be cautious and again, the prescribers, the dentists and doctors who make the decisions of the conditions for which the antibiotics are overprescribed. And then the conditions for which antibiotics might be appropriate, but are overdiagnosed. And then conditions for which antibiotics might be indicated, but then the wrong agent, dose, or duration is selected, such as selecting an antibiotic that is not necessarily recommended for that particular condition. And then conditions for which watchful waiting or delayed prescribing is appropriate but underused. And again, that may tee up with patient pressure to expecting to have care and relief from pain be immediate. And then finally, conditions for which antibiotics are underused or the need for timely antibiotics is not recognized. Now, I think I just want to add one more thing in there, is that so many times, I myself included, we feel better after being prescribed an antibiotic, so we stop taking it. And while the clinicians don't have control over that, the control is in the communication to make sure that patients fully understand what the directions are for use, and to continue to use the whole prescribed dosage and amount and number of pills until gone, not just until pain has been eliminated or they feel better. Mary?
Excellent job, Leslie. And what I want to do now is kind of pull it all back together and focus it on what do we do in dentistry, because I'm sure that many of our listeners are thinking, okay, so now what? So I cannot emphasize enough how important it is for our listeners to go to the show notes, go to our website, and look at the resources there and access those resources. Because in addition to the CDC guidelines on antibiotic stewardship, the ADA has issued recommendations and results of a lot of research on managing pulpal and apical related dental pain and intraoral swelling. They have very specific parameters for prescribing antibiotics and what to prescribe, what drugs to prescribe. And the ADA has recommendations based on American Heart Association, based on the American Orthopedic Association on antibiotic prophylaxis. And those, again, are included as resources. So the recommendations, just to sort of summarize, for patients described in the ADA document for prophylactic antibiotics are for all dental patient procedures that involve manipulation of gingival tissue or the periapical region of the tooth or teeth, and perforation of the oral mucosa. So this is a lot of information for everybody to sort of digest. And I'm going to go back again to Linda's comment about have a training session on this so that everyone is up to date. I get questions all the time, I'm sure the other divas do as well, about do I need to pre-medicate my patient or not anymore? And we really need to have the most updated information. So I'll call on the divas for any final comments or any other thoughts on today's podcast. Olivia.
Just to dovetail off of what you had just said, Mary, dental practices may find it helpful if the dentist actually writes a simple position statement in, layman terminology of why or why not antibiotics would be prescribed, so that if a patient tries to debate with the dentist, they're not bombarding them with medical literature, but rather putting it in a format that they could understand and hopefully educate that patient.
Oh, that's an excellent suggestion, Olivia. And I also like the idea of having that perhaps even on the practice website, so that if someone calls, if you have an emergency, here's the protocol. And by the way, here is our policy on antibiotics and pain medication. I know my own personal physician has signs in all of their exam rooms that say, we will not do this, and it is the conditions for not prescribing antibiotics. So as I'm sure our listeners can appreciate, this is a pretty meaty topic here to do some follow-up research on, do some training, read through the current guidance, and we hope that you will. We thank you for your participation. Remember that the Compliance Divas brings clarity and simplicity to regulatory compliance by navigating that regulatory world to keep you on course. Please submit any questions or feedback to support@thecompliancedivas.com. The resources from today's podcast will be in the show notes and on the compliancedivas.com website. Thank you for joining us.